Good morning, everybody. We are happy to have you here. We will start today with Professor Adelaide Rapp, Professor of Psychopharmacology. Her talk will be about the treating of ADHD and depression in people with epilepsy. Thank you. Please.
All right. Well, there's not a lot of people, so this should be pretty easy. So we're going to talk about ADHD and depression because they're two of the most common psychiatric comorbidities, and many people think if you have epilepsy, you shouldn't put people on psychiatric medicines because it's going to make the seizures worse. So we'll talk about that. So, I want to talk about the overlap in epidemiology between these two psychiatric disorders, the DSM 5 criteria rather than ICD 10. Please forgive me, in the US we use DSM 5. Some of the rating scales that are available in Arabic for ADHD and for depression in people with epilepsy, so you can actually do a quick evaluation in your office. And then talk about pharmacotherapy for ADHD as well as digital treatment. There's a computer program in the US that's FDA approved, and then talk about pharmacotherapy and psychotherapy for depression. So when we look, oh, that's a giant dot, about 20% of people with epilepsy have psychiatric illness, and 70% of people with intractable seizures have a psychiatric comorbidity, including depression, anxiety with panic attacks, and even psychosis, which will sometimes show up. Sometimes we'll see what we call postictal psychosis. Somebody could come in with status epilepticus, wake up, and have psychotic symptoms. Major depression and ADHD rates as high as 20%. So, when we looked at 801,000 patients with ADHD from ages 5 to 64, we saw that of all of those, about 0.4% or 3,000 patients had at least one seizure event. So if you're looking at all of the people with ADHD, a small percentage of them have seizures. This is just the DSM 5 criteria for the inattentive half of ADHD. So it's poor attention to details, can't keep your attention on things, not listening when you talk to you. So parents will complain about this. I tell my child 50 times to go get their books for school and do their homework, and the kids don't listen, not finishing chores, not doing instructions, not doing things that are difficult like homework, losing things. They lose their keys, they lose their sweater for school, they lose their school books, and they're easily distracted and they forget to bring their homework back to school or they forget to bring their homework home from school. And then hyperactivity and impulsivity. So that's not sitting in your seat, getting out of your seat in the classroom. In the US, they want you to sit in your chair. You can't get up and walk around. Running or climbing things, being noisy, on the go. This is one that we often forget about, and this is one that girls often get in trouble for, talking too much. The teachers will say, this girl is very social, a social butterfly, they call them. Shouting out answers before you're called on, not waiting your turn, and interrupting. So if grown-ups are talking, the child will be like, Mom, Mom, Mom. And the parents will complain about that. So for depression, you have to have 5 symptoms of either a depressed or irritable mood, and anhedonia, which is lack of interest and pleasure in things. Football is no longer fun. When a boy comes in and tells me I don't want to play football anymore, that's a bad sign. Can't have another medication or a medical problem that causes it, and they're not doing well in school or at home. So, changes in sleep, loss of interest, feeling guilty. It's my fault that our soccer team lost. It's my fault that my grandfather is sick. Poor concentration again, changes in appetite, being physically restless or very slow, and thoughts of suicide. So we have some rating scales that are available in Arabic. I always think it's helpful to know that. The Saudi Arabian Society, I couldn't find an Egyptian reference. I'm sorry about that. But the Saudi Arabian Society, and that's the website if people want to take a picture, has the forms for ADHD rating in Arabic. There's also an adult rating scale called the Adult Symptom Rating Scale, the ADHD Symptom Rating Scale for adults. And there's a lovely review article that came out in August of 2019 looking at different papers of adult ADHD across the Arabic world. Three of the examples they gave were actually Egyptian examples, but it's about 22 different countries that had reports of adults with ADHD. And this is the Vanderbilt, and I'm just going to walk out for a minute. So this is for me, it's none, mild, moderate, and severe. And the first 9 questions are the inattentive questions, and the second 9 questions are hyperactive and impulsive. And so it's easy to get a copy of this from that website that was on the previous slide. And if you've got a parent in the office with a child who's not doing well in school, you can quickly give them that and total up the scores. And that will tell you whether they meet the criteria for ADHD or not. And then you can track it with treatment to see if somebody's getting better. So there's also a very famous rating scale for depression in the context of epilepsy. And it's called the Neurologic Disorders Depression Inventory for Epilepsy. And there is an Arabic version of this. There's a nice paper that came out in March 2014 from Epilepsy and Behavior. Dr. Hadil is the first author on that, and the reference is there. And it was 51 patients with a diagnosis of epilepsy, and they compared scores on the Beck Depression Inventory, which is a classic rating scale done by psychiatrists for adults with depression, and compared it to the NDDI in Arabic to look at the difference between how many people on the Beck were positive for depression versus the rating scale for epilepsy specific. The cutoff score on the Beck was 20, and that was moderately severe depression, and the NDDI in Arabic had both positive and negative predictive values. So it's another rating scale you can do in your office if you're concerned about depression in one of your patients with epilepsy. And it is both reliable and sensitive to identifying depression in people who are Arabic speakers. So now we're going to switch gears now that we have some good rating scales to use and talk about treatment. So in children, there's a paper that came out in 2016 in the Pediatric Neurology Briefs was published online looking at 167 children with epilepsy and ADHD. They were ages 6 to 17. And then another 91 that were just ADHD alone. And it was a prospective, so following you forward, open label trial where they were either on methylphenidate or no medication. They used the Vanderbilt, which we've already talked about, and the average score was 30. So this is moderate to severe ADHD, and they were started, 61 of the children in the trial were started on methylphenidate, and they looked at an improvement as a 25% reduction in your ADHD symptoms. That's a fairly modest improvement. It's not marked. These kids would still be noticeable in the offices, not sitting still and maybe not focusing all that well. But of the children on medicine, 75% of them got better, and of the children who were not on medicine, only 42% got better. So that's a p-value of 0.0001. That's a marked difference. So the medicine in kids with epilepsy reduced the symptoms and made a big difference in functioning. the medication response was actually better in girls than it was in boys, and there was no other difference in who was going to be a medicine responder. But what we worry about, what you worry about, is I worry about the ADHD, you worry about the epilepsy. And what you want to know is if I treat a patient with medicine for ADHD, are their seizures going to get worse? And so they looked at seizure recurrence, and only 4 patients, or 12%, of the people who were already seizure free, so they had no seizures going into the trial, 4 out of those 32 patients had a seizure on methylphenidate. So there were some people who had also already had seizures, and about 3% of them had a worsening on methylphenidate. But there was not a statistically significant difference. There's also a large review done in the Cochrane database that came out in 2022. So that's a very recent, up-to-date meta-analysis review. They looked at all of the trials of stimulants and non-stimulants for people of any age with epilepsy. So they took all the trials. And from 1937 to 2020, there were 2 trials that they could find. That's not a lot. One was on oral methylphenidate in the United States. It was 33 children. That was done by one of my colleagues who's at MGH, Dr. Gonzalez. And then there was a trial in Iran of omega-3 plus risperidone for people already on an anti-seizure medication. In the oral methylphenidate trial, which was the one that was done in the States, there was no significant worsening of epilepsy in the people assigned to methylphenidate compared to placebo, no generalized tonic-clonic seizures, and no intensification of seizures. So in a randomized placebo-controlled trial of kids with epilepsy, there was no difference. But having said that, if you went higher on the dose of methylphenidate, you were more likely to have an increased risk of seizures. The other thing I would remind people is if you were on carbamazepine, you guys use that here? In Egypt? A lot. Okay, thank you. And you're on methylphenidate, a long-acting methylphenidate, sometimes the ADHD will get worse. And the reason is it shortens the half-life of the oros methylphenidate. So parents may come into you and say the ADHD is getting worse. All you have to do is go up a little bit on the dose if they're on carbamazepine specifically. The omega-3 trial, the main seizure frequency was around, on average, 6.6 per month, but there was no data on improvement of ADHD, so they're not really convinced that risperidone and or omega-3 made a difference in the ADHD symptoms. They cared more about the seizures. So when you're thinking about it, you want to think about treating the target, which is the ADHD symptoms, comorbidity in people with epilepsy, newer agents, the non-stimulants, if you will, whether you need to do combination treatment, and do people have a preference in the head-to-head comparison. So I like this slide because it's got every single medicine we use and where it binds. So when we're dosing the psychostimulants, so that's methylphenidate and amphetamines, we dose methylphenidate. This is for our pediatric colleagues, 1 to 2 mg per kilo per day. Amphetamine 0.5 to 1 mg per kilo per day. We have a number of non-stimulants that we use. Clonidine and fluoxetine or alpha agonists that are FDA approved to treat ADHD in the States. And amoxicillin is a norepinephrine reuptake inhibitor, as is fluoxetine, which was used for a number of years in Europe to treat depression and anxiety. Was it approved in Egypt as well? Only at amoxicillin. All right, and one we use in the United States for people without epilepsy is bupropion. But as you all know, bupropion lowers the seizure threshold. One of the worst things to give somebody with epilepsy is bupropion. Not ever use that. Treat ADHD. more for complete. So we have the most information about stimulants. We've been using them for more than 60 years. The effect size is about 0.8 in adults for stimulants. It's even higher than that in children. It's about 1.0 effect size for stimulants and ADHD. And for non-stimulants, it's about 0.6. It doesn't matter whether you're using clonidine and guanfacine or whether you're using atomoxetine or the other norepinephrine. And there are no guidelines to support, unlike epilepsy, there are no guidelines to support do you go with a amphetamine stimulant or a methylphenidate stimulant unless you have family response to one or the other. So if somebody comes in and says, my brother's son did well on amphetamine, then you're going to put that patient on amphetamine rather than methylphenidate because you have a family response of a good response to one medicine or the other. And it's important because 91% of patients with ADHD will respond to one or the other. So if you fail amphetamine, you should have a trial of methylphenidate before you go to the atomoxetine is a norepinephrine transport antagonist. It increases norepinephrine and dopamine in the prefrontal cortex. Clonidine and guanfacine are, well, clonidine is an alpha 2 A, B, and C. Guanfacine is a little bit more specific for 2 alpha only. And then fluoxetine is another norepinephrine transporter antagonist. They all increase things in both the prefrontal cortex and other parts of the brain. So there is a digital treatment. I still find it a little hard to believe. I'm a bit of a skeptic that you can improve ADHD symptoms by using digital training rather than medicine. But we also know, for some people who have photosensitive epilepsy, that video games can make your seizures worse. So this is, again, maybe not the first thing we would go to for treatment of ADHD in the context of epilepsy, but some parents don't want another medicine, and so we will often try this in the United States. It is a game-based treatment for ADHD in children 8 to 12 only that have demonstrated attention problems. They play the game at home for 25 minutes a day, 5 days a week for 4 weeks. And it's part of a larger program that includes clinical therapy, medication, and/or changes in schooling, and had improvements in attention based on computerized testing. So what they saw actually was improvement in both attention and cognitive control, but the data is not there for that. And an improvement on the TOVA, which is the test of variable attention, with this video game, and no serious side effects. None. So they didn't, for instance, get headaches. They didn't develop seizures from this, and people didn't drop out of the treatment because it was a video game. 83% compliance. That's pretty good. We can't get our patients with ADHD to take medicine that. They also looked at it as an add-on to people who were either on stimulants or not on stimulants. So 130 kids on stimulants already, another 76 not on medicine, and had a reduction again in the ADHD symptoms over time. I'm going to switch gears and talk about depression because I think that's an even more impairing illness. So antidepressant drugs can exert differentiated effects on the convulsive threshold. And there are a couple of them that can lower seizure threshold. Menanthrin, trazodone, reboxetine, venlafaxine can potentiate anticonvulsant activity so they can actually change your levels of your anticonvulsant medicines. And conversely, there are some seizure medications that may actually give you psychiatric symptoms. I have a whole list of medicines that I don't like to all use on a regular basis. I will say I like the moxetine. Losing weight, they're not going to work, they're not doing their schoolwork, then it's time to think about medication. And with epilepsy, can tolerate a number of antidepressants. And per the guidance of the International League Against Epilepsy, SSRIs are first line. And at the end of the talk, I'm not going to go over it, I've listed all of the cytochrome P450 medicines that can interact with your epilepsy drugs and your antidepressants. In general, of the SSRIs, the one that I tend to pick is actually either citalopram or escitalopram, because that primarily goes through CP19 and it doesn't have a large range to titrate. Escitalopram is 5 to 20 milligrams a day and you're done. That's it. And it doesn't have a lot of drug interactions with the most commonly used anti-epileptic drugs. So when I have a person with epilepsy and depression, I go straight to escitalopram. That's what I do. If that works, there is a trial in 2019 of 140 adults with depression and epilepsy, and they actually got sertraline, which also works, but the range is 25 to 200, so there's a lot of. So they had either sertraline or cognitive behavioral therapy, which is the evidence-based therapy for depression, and it was specifically designed for depression in epilepsy, so it was modified for those patients. And both medicines were effective, and medicine works for 53% of patients, CBT for 60%, in comparison to placebo, which was only 33%. Both treatments were effective, and so there you might, if you have CBT, but if you're telling people to get cognitive behavioral therapy, you have it. So then it becomes a patient choice. Do you want to try therapy or do you want to try medication? They're both effective. They also look at the quality of life for people with epilepsy, and 28% of people on sertraline, 25% on therapy, also noted an improvement in the quality of life with the improvement in the depression. And most importantly, sertraline did not increase the risk of generalized tonic-clonic seizures or suicidal thoughts. So it was safe for both epilepsy and pain. There was also a large trial that was published in Seizure in 2017 that was a massive analysis of 10 trials in looking at cognitive behavioral therapy and mindfulness, which is much more like a meditation type of therapy. Mindfulness-based cognitive behavioral therapy, including topics of acceptance and commitment, which really means, yes, I know I have depression, I know I have epilepsy, I'm going to work on feeling better. And that improves both the, I don't know why it's flashing out like that, but the depression and the quality of life. then you tackle the depression. And really, the seizures are the biggest struggle that we feel like our seizures are under control, then we can tackle the depression. They also think that things like wellness, exercise, and sleep hygiene. You all know for your patients with epilepsy, if they're up late studying for final exams and they're not getting enough sleep, they're not exercising, they're not eating right, they're more likely to have seizures. They're also more likely to have depression if just can't manage as well. And so that's something that you do in your office to say, are you exercising? Are you getting enough sleep? Are you eating a proper diet? Because those will help your patient before you ever get them to it. And those are all easy things to do. Pediatricians do it every time they do a checkup. How are you sleeping? How are you eating? And it's important to do that for our patients with epilepsy. So there are only two medicines in the United States, most of the rest of the world, that we use for depression, and that is fluoxetine and, again, the escitalopram. And those are our first choice. FDA approved for depression and for obsessive compulsive disorder. There are two large clinical trials that showed it was effective to treat depression in about a 2-to-1 ratio compared to placebo. And this is just being changed in pediatric depression rating scale on placebo, and here's flat depression symptomatic. I was part of the team that did the escitalopram trial, and that's now FDA approved, but only for 12 and up. And again, the dose on citalopram is 20 and 40. And on escitalopram, which is the active enantiomer, it was 10 and 20. And again, we see that same difference where active drug has been read, and by 2 weeks, we're already separating out, going all the way out. They both work. Some important points I want to remember for all of you. Epilepsy is highly comorbid with both ADHD and depression.
Conventional 20 minutes or something like that.
So it depends on the clinical picture, because of course we know that absence epilepsy many times can look like ADHD. So if I get a report or I see a child, sometimes the children will come to our inpatient psychiatry unit for untreated ADHD, and we see them sort of staring, almost like a
Okay.
pause. We'll get an EEG then. The other time that we think about doing it is in children with autism and ADHD, because about a third of patients with autism have frank epilepsy,
Yeah.
and maybe another third have an EEG that is compatible with abnormal discharges that may look like epilepsy. Those people are at higher risk to have seizures or to develop seizures with both medicines for epilepsy and also, medicines for ADHD. And also, if we had to use an antipsychotic with certainly lower seizure threshold. And I'll tell you this is my favorite story. So I
Yeah.
have, as the wife of a neurologist and the mother of a neurologist, I always ask seizure history when I see people. Anybody in the family, has your child ever had it? I had a patient with autism. They were being treated by me for irritability and aggression. We put them on aripiprazole and titrated up to 30 milligrams because they were pretty bad. And one day they came into the office with their mother, and they were sitting there staring off into space going,
Mm.
I mean, so I'm like, this looks like partial complex and
Yeah.
it looks like status. So I ran down the hallway and found one of my neurology colleagues, and I said, can you come take a look at this patient? I think they're in partial complex status
Okay.
clinically.
Yeah.
And he's like, yep.
Mm.
So immediately call the epilepsy monitoring unit, get an ambulance, and send them over to the main hospital from
Yeah.
clinic. And I said to the mom while we're waiting for the ambulance to come, I said, I asked you about seizures and you told me no, and it was in the chart. She said, well, yes, she had them when she was little, and we stopped the medicine, they were gone. So I told you no.
Yeah.
So now I say, has your child ever had seizures? Not just, do you have seizures now? But you never know, because sometimes families believe if the problem stopped, the problem is cured,
Ah,
right? It's not coming
this is a
back.
big problem. Yeah.
And then you go on a medicine that could lower this threshold, and boom, they come back again.
Hmm.
So, especially in that population, that autism population, I'm even more cautious.
Okay. But in general, you don't use anti-seizure medication in treatment of ADHD because some people are using some molecules like carbamazepine because it causes some sort of sedation or decrease of the mood. Is it logic for you, this
So,
choice? No?
so back in the olden days when I
Yeah.
trained, and we had immediate release methylphenidate, amphetamine, and another medicine that caused fulminant hepatic failure, carbamazepine was third line for us. And we would use carbamazepine or a tricyclic antidepressant to treat ADHD. And we have so many more options now, we don't get to that. But we used to use it, and it works.
Yeah.
It works.
I'm asking you because,
Yeah.
in fact, we don't have a lot of these drugs. Just we have atomoxetine, Ritalin, or methylphenidate. We have difficulty to find it for all people. So
Do you have clonidine and guanfacine?
in the past we had, but right now, no.
Not even
Yeah,
So do you have the clonidine patches?
no.
Because I will tell you, when we have a really agitated patient with ADHD and intellectual disability, the transdermal clonidine patches are great. You put them on,
Okay,
and they last for a week.
okay.
And the parents are not chasing a child trying to get them to swallow medicine. And if you want to stop because the blood pressure is low, you just pull off the
Unplug,
patch. Yeah,
unplug.
you pull the patch off. It's
Very
great.
nice. Thank you.
So, are you asking about treating ADHD with anticonvulsant medications because of the concern for their seizures, or as a anti-ADHD medication? Are you asking about using carbamazepine as a way to treat the ADHD, or because you're or because they or because you think they have epilepsy? Okay, okay.
We are trying to use antipsychotic in some cases of ADHD or with depression. What's about the seizure provocation with these antipsychotic? Is there any option for you?
So we use antipsychotics to treat ADHD in patients with autism all the time. If you look at the FDA registration trials for irritability and aggression and autism for both aripiprazole and I have those slides on my computer, but I don't have them here, on both risperidone and on aripiprazole, one of the subscales on the aberrant behavior checklist is ADHD, and it goes down in parallel with the irritability and aggression. So it works. It works quite nicely. But those do lower seizure threshold. As I gave you the story of my patient who got partial complex status. So you need to monitor.
Do you use anti-seizure medications for the impulsivity in some cases of ADHD or even autism?
Not usually, unless they also have epilepsy. Only if they have epilepsy.
Okay, thank you. Thank you so much.